coming about those drugs for the chronic heart failure. So the thing is, what happens is we seek to transform the cancer care through distinctive scientific and clinical strategies which are focused on developing targeted immuno-oncology and combination therapies to create more effective uh, options for patients. However, we do need a similar uh, concept also in chronic heart failure therapies as well. How can we treat them, take care of them in a much better way? We all are aware about the heart failure is a life-threatening and a complex entity, which is in which the heart is weak and is not able to pump enough amount of blood to meet the full supply, uh, especially in terms of oxygen demand of the body, in fact. So that is why it is important to recognize the symptoms, and indeed, it is a leading cause of morbidity and also mortality, and it is indeed a complex syndrome and therefore difficult to treat. So that is why we should be able to see the characteristic enlargement of LV and decline in the ejection fraction. Okay, so a lot of times we may be able to catch hold of those patients who are presenting without symptoms as well. So there is a huge range of long terms which is used for describing the heart failure, like the acute heart failure and chronic heart failure. So chronic heart failure, we are, as we had already said it, it is persistent, progressive condition that is often interspersed with acute episodes, either stable, otherwise worsening, or even decompensated. In fact, about the acute heart failure episodes, the acute episodes of heart failure symptoms that need hospitalization and emergency treatment. And we all are aware uh, uh, the heart failure patients can have reduced ejection fraction, otherwise preserved ejection fraction. So in the preserved ejection fraction, mostly they tend to have only diastolic dysfunction. The ejection fraction is going to be more than 50%, and yes, in fact, even now it is less well understood, although it is less deadly than the reduced fraction uh, and less um, mortality compared to the one with reduced ejection fraction. But when you think about the what shall we be doing with that, the number of therapies available is really, really less. The heart failure entity with reduced ejection fraction, as I already said it, there's mostly systolic dysfunction. So ejection fraction is less than 35%, okay? And this is the one which has been really studied very, very well. And so what about the pathophysiology? So the pathophysiology wise, we do understand there's damage to the cardiac myocytes and extracellular matrix that leads to change in the size, shape, and function of the heart and cardiac wall stress. This is the one which leads to systemic neuronal overactivation, in fact, which leads to maladaptive remodeling and hemodynamic alterations, which are responsible for the morbidity, mortality, and also the symptoms of heart failure. And these are the ones which will be associated with the vasoconstriction, fibrosis, apoptosis, the hypertrophy, the cellular and molecular alterations, and also myotoxicity. So these may be good in the short term, but in long term, these are the ones which will be causing those symptoms and the problems. Symptoms like the dyspnea, edema, fatigue, and also finally leading to arrhythmias or even pump failure as well. So, regarding the overactivation of the RAS and sympathetic nervous system, as we can see it very well, there are three components. There are different components of it. The symptoms and the progression leads to three different components. So on the RAS side, what is happening is angiotensin 2 getting mediated to the angiotensin 1. So this is the one which is leading to vasoconstriction, which leads to all these problems like the blood pressure, aldosterone is increased, hypertrophy is increased, fibrosis, sodium and water retention. Similarly, on the other side is sympathetic nervous system in the sense like which is the one which is going to lead to all these other problems like the RAS activity is increased, vasopressin is increased, heart rate is going to be increased as well. Then on the other side, due to its mechanism involving the natriuretic peptide system, it is going to cause vasodilatation, due to which there will be lower blood pressure, sympathetic tone will be lower, natriuretic natriuresis is going to increase, the aldosterone is going to be lower, in fact. Okay, so this is the reason we have to we have been focusing recently on quite a lot on the natriuretic peptide system. Can we do something to counteract for the its mechanism, for example, through the sympathetic nervous system and the RAS? So already the heart failure severity is classified according to symptoms. The NIHA functional class is widely used to grade symptomatic syndrome of heart failure in clinical practice and has been used to select patients in almost all randomized treatment trials in heart failure. The differences between each class are based on how much breathlessness, fatigue, or palpitations a patient experiences when they undertake physical activity or at rest. As we can see, NIHA class 1 have no symptoms attributable to heart disease, and those in class 2, 3, 4 are having mild, moderate, or severe symptoms respectively. So, as we already said it is heart failure is a progressive condition with high mortality rate. There is higher frequency of acute events with disease progression leading to decreased function and quality of life. And with each acute event, myocardial injury may contribute to progressive LV dysfunction, resulting in increased risk of mortality and also higher rate of hospitalization. Right? About the pharmacotherapy, so we already said it about the introductory therapy, then the centerpiece, and finally coming to the cornerstone in therapy as well, and the final therapies if none of them is able to help. So what has been happening is um, the heart failure therapies has been going on since a long time. Long evolution has been there. So one of the first studies which came was in 1991 called as solved T. So that is the one which showed the first benefit of enalapril compared to the placebo. And then came the CBUS 2, which again showed the benefit of bisoprolol versus the placebo, having a significant mortality benefit. Then in the 2003 itself, there were two studies, the charm alternative, showing about the key benefits of candesartan, which was the ARB, again showing the mortality benefits, and the charm added again showed the candesartan versus placebo, showing the mortality benefits on hospitalization, in fact. Then was shift study showing about the usage of ivabradine. And then came the emphasis heart failure study, which showed the key benefits of eplerenone versus placebo. And then we all are aware of the landmark trial, paradigm heart failure study, which was about the LCZ696 molecule, which is the ARNI. And the thing was, it was not against placebo, it was placed against enalapril. And there was still 20% cardiovascular mortality benefit ratio, in fact. So there are a lot of other studies as well, consensus study about the enalapril, the VHEFT. So as we notice, so most of these, as I said, these are all about ACE inhibitors. They were able to see or show mortality outcomes really significantly benefits were there. There has been various studies as well which focused upon the ARBs, um, uh, like how, for example, targeting the losartan, valsartan, or even the candesartan as well. How are they affecting the uh, uh, treatment of patients with chronic heart failure? And they do indicate that the ARBs do provide significant reduction in risk of mortality and also the heart failure hospitalizations compared with placebo. Now, coming to the beta blockers, there has been a significant number again of pivotal studies of beta blockers in the treatment of patients with chronic heart failure. And these studies indicate that beta blockers do provide significant reduction in risk of mortality and also for hospitalization. And now for the MRAs. MRAs, why? For example, like the spironolactone, the eplerenone. So what has been happening is they are the ones, uh, yeah, again, especially for the chronic heart failure patients, has been giving significant reduction in the mortality and the hospitalizations as well. So, for example, if we try to see it over here, the relative risk reduction was one of the highest with eplerenone. So, whenever they were used up to 50 milligrams, and however, the number needed to treat was over here was 14. Okay. Similarly, even with the spironolactone, the real study showed the relative risk reduction was almost 30%, although the number needed to treat was 10. So it's again a landmark and very significant study which showed us the path how to be taken care of for the management of these our beta blocker patients as well. So with passage of time, the survival has improved. However, the mortality remains high. So here is a beautiful slide which tends to compare all of them. So morbidity is still high and mortality as well with the current therapy. So what can we do? So heart failure is indeed common and the prevalence is not decreasing at all. In fact, 20% of the patients over 40 years and over is they are going to develop heart failure in their lifetime. And in fact, this is the most rapidly growing cardiovascular condition. And it does increase the mortality in the sense. So, what happens? Up to 50% of the patients with heart failure tend to die within 5 years of diagnosis. And uh, in fact, what happens is, yeah, the death rates as well is pretty high for such kind of patients. And hospitalized for the hospitalized patients with heart failure, the 1 year death rate can vary from 20 to 45%. And it's and definitely, so we can understand very well is there is significant increase in mortality for such kind of patients. So that is why there are several recent advances as well in the heart failure management, including various drugs, which we can see it over here, and um, and there is also a increasing interest in role of microRNAs in heart failure. MicroRNAs are small, non-coding RNAs that regulate gene transcription and protein formation, and it has been shown uh, that Valquist et al. Were able to identify the microRNAs that suppress intracellular calcium handling in heart muscle by interacting with messenger RNA encoding, the sarcoplasmic reticulum calcium uptake SCRCA2A. In fact, so these seem to be something interesting. For example, like the ivabradine. It was approved by the US FDA in like 2015, although it is a funny current inhibitor, but it is indicated to reduce the risk of hospitalization for worsening heart failure in patients with stable, symptomatic, chronic heart failure with for the patients having a low ejection fraction of less than 35%. And those patients, and it should be reserved for those patients who are having uh, uh, in sinus rhythm only. Okay, and they should be considered only after someone has already been given uh, a highest or maximum tolerated dose of beta blocker has already been given. In fact, this drug blocks the hyperpolarization activators HCN, the cyclic nucleotide gated channel, which is responsible, sorry, which is responsible for the cardiac pacemakers, and the funny current, which regulates the heart rate without any effect on ventricular repolarization or myocardial contractility. So, this was the SHIFT trial, which we already spoke about. Okay, uh, which really showed a lot of evidence, especially in terms of the mortality benefits, and that's how it got into the guidelines as well. So we have already spoken about it, about the overactivation of the RAS and SNS is detrimental in reduced ejection fraction heart failure patients and underpins the basis of therapy. The crucial importance of RAS is supported by the beneficial effects of ACE inhibitor, ARBs, or even MRAs. And the benefit of beta blockers does indicate that sympathetic nervous system also plays a key role. There are significant beneficial actions of the natriuretic peptides, which includes, and they are expressed in the brain, kidney, heart, and vasculature. We all are aware the natriuretic peptides are cleared via the NPRC and degraded by the protease neprilysin 1. Natriuretic peptides are cleared from the body primarily by either by receptor mediated degradation or degradation by the enzyme neprilysin. The primary role of NPRC is to bind, internalize, and then enzymatically degrade to NPs. And NPRC binds with high affinity to all three natriuretic peptides. Neprilysin hydrolyzes the ANP, BNP, and the CNP. CNP stands for C-type natriuretic peptides into inactive fragments. This is another important figure over here in the sense like here as you can see NAP metabolizes angiotensin via several pathways. Inhibition of NAP alone may increase the angiotensin II levels, and counteracting the potential benefits of NAP inhibition too, the NAP inhibition must be accompanied by simultaneously RAS blockade, for example, a angiotensin 1 receptor blockade. Okay, so that's what we see over here, right? Beautiful animation. So, angiotensin neprilysin inhibition evolution. So, what do we see over here? So, if only neprilysin inhibition alone is done, so it seems to be ineffective due to the angiotensin activation, due to which neprilysin inhibition plus ACE inhibition, when it is done, this is the one potentially dangerous due to angioedema, and that is where the neprilysin inhibition plus ARB blockade as well. So that is where comes the LCZ 696 is a novel drug which delivers simultaneously neprilysin inhibition and also angiotensin 1 receptor blockade. So this salt complex comprises two anionic moieties in 1:1 molar ratio consisting of sacubitril and valsartan. Sacubitril is a prodrug which metabolizes to the neprilysin inhibitor LBQ657. Yeah, and valsartan, as you all are aware, is an angiotensin 1 receptor blockade. So LCZ696 simultaneously inhibits the NEP via the LBQ657 and also and blocks the angiotensin 1 receptor via the valsartan. As the neprilysin enzyme degrades the NPs as well as also the vasoactive peptides, inhibition of neprilysin enhances the effect of these peptides, including vasorelaxation, natriuresis, and diuresis, and inhibition of cardiac fibrosis and hypertrophy. And in addition, since the NEP is involved in the breakdown of angiotensin 2, simultaneous suppression of the RAS by LCZ696 is important to offset any potential effects of an increase in angiotensin 2 resulting from neprilysin inhibition. Of note, the biologically inert anti-proBNP is not a substrate for neprilysin and as such still represents a marker of cardiac wall stress even in the setting of neprilysin inhibition. So, as we all are aware of the prospective comparison of ARNI with ACE inhibitor to determine the impact on global mortality and morbidity in heart failure was the first study to test this unique molecule, focusing on the mortality and morbidity benefits for such patients. And as we all are aware, um, since the SOLVE T trial itself, this is the only ACE inhibitor in enalapril, which does have a broad spectrum reduction in mortality of such patients. And enalapril 10 mg BD was chosen as the appropriate comparator dose because this is the gold standard on the basis of SOLVE T and also the consensus trial data. SOLVE T was they are the ones which included patients with mild to moderately symptomatic heart failure, and consensus it had included severely symptomatic heart failure patients, in fact. So what was happening is the rationale for LCZ696 dose selection uh, was what was happening is the LCZ696 200 milligram delivers similar exposure to valsartan, okay, like it's the 160 mg BD of the combination, in fact. So that is why uh, this dose is recommended. Similarly, both the LCZ696, it's two molecules like the in form of dosage in the form of 400 and 200 milligram provided meaningful pharmacodynamic effect, BP lowering, which was attributable to NEP inhibition, and the BID dosing is considered essential to obtain 24-hour NEP inhibition. And the BD dosage mitigates the risk of post-dose hypotension. So that is why two smaller doses it will be better compared to a single uh, large dosage, in fact, right? So there has been various exclusion criteria as well about this paradigm heart failure study. If someone is having angioedemas, contraindication in the terms of hyperkalemia, if someone is already must take ACE inhibitor ARBs, someone is having hypotension or decompensated heart failure, or even pulmonary disease is there, or someone is having any of the contraindications like the stroke, uh, transient ischemic attack, or the carotid, or the PCI, or carotid angioplasty as well. So it is better to avoid such kind of patients. And the endpoints were, of course, those patients who were unable to tolerate the dose of Study drugs were down titrated to the lower dosage to the discretion of the investigator. So here we can beautifully see those patients who were on enalapril and the other group of patients who were there on this molecule. Okay, and of course those parameters were pretty much comparable as well. So over here, so what were the key results? So we can already see there was significant reduction in cardiovascular mortality, morbidity, and also lower hospitalization as well. And there were, of course, multiple secondary outcomes as well, which it was able to fulfill in the sense uh, it could, uh, there was no significant onset of new AF, otherwise, renal function didn't get reduced at all for such kind of patients as well. So, due to the significant reduction, which was, I would say, like in nearly 80% of those patients, the deaths, we all are aware that uh, that majority of those death of those patients is always due to a cardiovascular cause, and there was a significant benefit for such patients, and this is the reason it got into the guidelines. In fact, and in fact, uh, as we can see it already over here, for ARNI it was B, in fact, and COR was 1, and level of evidence for ARNI is BR, in fact, over here. And even it got into the ESC guidelines as class 1B, in fact. But we should always be careful. What about those contraindications? Contraindications should, like hypersensitivity, angioedema, and if someone is using ACE inhibitors at the same time, better to avoid it. And if even similarly for the simultaneous use of aliskirenine as well. What about the other therapies other than this? We all should be careful. We must give it to the patients. So, for example, if someone is having, irrespective, I would say, someone is having iron deficiency or not, it is better to always prefer intravenous therapy for such patients. So, try to give FCM weekly 200 mg, okay, using the Ganowski formula, and we can similarly see this as well. So, we must be able to take care for the iron deficiency as well. So this is something very important, as I already said it. I can't emphasize more. So this is one of the things which we always miss it, in fact, for such kind of patients, that okay, there's no need for iron therapy and all. So this is what I would really suggest that we should keep it in our mind as well. Okay, thank you so much. Are there any questions?
Hello, Dr.
Yeah,
Narendra.
yeah, yeah.
Yeah, thank you so much for the wonderful presentation, doctor.
Thank you.
Students, do you have any doubts?
Are there any doubts or any